Good morning. All right. Well, welcome, and I guess thanks to your teacher so that I have a bigger audience. I didn't know that was happening on the last day, but that's great. So I guess before I start talking and forget, there are pictures of dead animals and parts of animals. So if anybody's squeamish, just a warning. That's pretty much what pathology is about. So kind of hard to do the presentation about that. So like Martha said, I'm Kelli Almes. I'm a veterinary pathologist down at the Kansas State Veterinary Diagnostic Lab, which is a unit within the College of Veterinary Medicine at Kansas State. So I promise I will talk fast on some of these. If you guys have questions, even in the middle of while I'm talking, please just raise your hand. Feel free to interrupt. I'm totally fine with that, okay? So first, I'll just start off by telling you a little bit about pathology in general, how I ended up there, and then we'll go over a couple cases. I have 3 in here, and if we run out of time, we'll do 2 of them. We'll just see how much time we have. So pathology is divided into anatomic and clinical pathology. So anatomic is what I do. That's necropsies or autopsies of animals. Biopsies, which would be if your cat or dog has a little lump on it somewhere and you take it to the veterinarian and they take it off in surgery and send it in to see if it's a tumor or what type of tumor it is. And then clinical pathology deals with blood, urine, joint fluids, cerebral spinal fluid, that type of thing. Lots of commonalities between the two of anatomic and clinical pathology. So first of all, you have to be a graduate DVM to do either one of those specialties. It's both sort of a form of biopsy. So clinical pathologists read biopsies in the form of what we call a fine needle aspirate, or if you just take a needle and put it into a lump or bump and they look at that on a slide under the microscope. We get the advantage of looking at the whole lump or bump under the microscope after the veterinarian takes it off. Obviously, I've mentioned microscope several times already. It's a lot of microscope work, a lot of glass slides, but it's obviously part of the patient case as a whole, and it is an integral part of veterinary medicine, private practice, all that kind of stuff. Training is the same for both clinical and anatomical pathology. You do get to skip an internship. So if you go into many of the small animal specialties, if you guys heard from any of those folks earlier in the series, oncology, internal medicine, surgery, and in that you do a year-long internship and then a 3-year residency, so it's 4 years after that school. You don't have to do that internship for pathology, so you do get to save a year. So you can go straight into residency. Still a 3-year program, you still sit for a board exam, which is 4 parts, and then we have the same college, as we call it, so we're boarded by the American College of Veterinary Pathologists. So that includes both anatomic and clinical. Anatomic specifically, so what we're trying to do is get a diagnosis of disease based on macroscopic, or what you can see with your eyes, microscopic, biochemical, immunological, and molecular examinations of organs and tissues. So we have lots of different tests that we can do on those tissues once we get the sample or once we necropsy the animal. And then obviously for veterinary pathology, we are covering anything that shows up. So we never know what's going to walk in the door. We do necropsies every day, Monday to Friday, and on Saturdays. And it can be anything from a cow to a tiger to a chicken. We never have any idea what's going to show up. We do biopsies, as I mentioned, and then what we call mailing cases. So some veterinarians, mainly large animal veterinarians, but also some small animal veterinarians, do their own necropsies. So they will necropsy one of their clients' animals that has passed away or been euthanized. They will take samples, and then they will send the samples to the laboratory. And then it's our job to read the history, work with that veterinarian, and figure out what testing they would like done, and or look at all of those tissues under the microscope for them. So this is what people think we do, but it's not what we do. So we do not have awesome machines that we can get really quick answers in. Everything takes time. People think veterinarians in general are super fast at getting test results. We're actually amazingly much faster than most human medical testing. But some people think it's still not fast enough, so. Just some random stuff about it. So if you go into anatomic pathology, then there's many things you can do with that specialty after you finish your residency. So what I do is work as a diagnostic pathologist. So all of those things that I just talked about, and the main thing we're looking at is disease investigation, right? So we're trying to figure out why an animal died or why its treatment didn't work or something along those lines. So a lot of times that's a herd level if we're talking about food animals, or obviously an individual animal level if we're talking about companion animals. Testing recommendations, so we get calls all the time from veterinarians. They might have a puppy that's sick and they need help figuring out what test they want to do and what sample they need for that test, and they call us to talk to us about that. Then prognosis, so that way we can, if we tell them it's a type of tumor, we also are expected to know what that means. So does that tumor usually not grow back? Does that tumor likely to grow back? Does that tumor metastasize frequently? What are the options? We can't give treatment options. They have to go to a clinical practicing veterinarian for that. You have to have a veterinary client-patient relationship to be able to offer treatment recommendations, prescribe medicines, that type of thing. But we can give them some sort of prognosis. Teaching. So every veterinarian, as you go through veterinary school, has pathology class. So at K-State, pathology is 2 semesters long, and it is 2 hours, 3 days a week in the fall semester for general pathology. So that's more talking about at the cellular, molecular level. But in the spring, it's 3 hours, 3 days a week for what we call systemic pathology. So that's when you start going through the gastrointestinal system, and then you go through the cardiovascular system. And that's more of an animal level, disease specific type semester. There's lecture and laboratory periods for that. And every veterinary degree has pathology in it. And then as a senior veterinary student on 4th year during clinics, you spend 3 weeks on the necropsy rotation, helping perform the necropsies every day. And then, as I mentioned before, a lot of large animal veterinarians do their own necropsies. So you need to learn how to do that when you're in veterinary school if you want to go out into practice and do any large animal work. And then research. A lot of pathologists in research settings, you can be what they call an investigative research pathologist. So that's sort of helping discover new things, studying new diseases, that type of thing. And we have some of those at K-State as well. And then there's pharmaceutical research. So those are the folks that are trying to figure out if there are any side effects from new drugs, right? So drug development, and that's usually in industry at some of your bigger pharmaceutical companies, not so much in university setting, but there's a lot of options within anatomic pathology. So I grew up on a really small cow-calf farm in rural Kansas, about 2 hours from here. I went to a high school. There were 12 people in my class. We played 8-man football. They still play 8-man football there. A super small town. Went straight to K-State, did my undergraduate degree, and then graduated with my DVM in 2005. And during clinics, your 4th year, you do have the option to do what they call externships. So if there's something that you think you want to specialize in and you want to get more hands-on experience, you can leave K-State and go do that. You have to find the opportunity yourself, pay for it yourself, which can sometimes be a little rough during vet school, but you have to search those out and get those approved, and then you do get credit for those. So I went to Plum Island for 3 weeks, which will soon be replaced with MBAF in Manhattan. And then I also went to, at that time, what was called the Armed Forces Institute of Pathology, which was in Washington, D.C. at the Walter Reed Hospital Center. There's a whole huge complex there. That place no longer exists, unfortunately, because the Army restructured everything due to funding. But it is where the military trains all of their pathology residents. They have a pathology residency program. It's now called the Joint Pathology Center. It's still in DC, but it just kind of changed a little bit. So I did those 2 things to make sure that I was prepared to never practice and that I felt comfortable going straight into a pathology residency and that I wasn't going to feel like I was missing out on anything. So I really enjoyed clinic senior year. I liked working with the animals, with the animal owners. I really, really liked pathology. So I decided I would go straight into pathology, and I never went into general practice. Did my residency from 2005 to 2008, and then I've been working as a diagnostic pathologist ever since. And then on the side, since I work at university, you usually get some administrative duties as well. So I'm the director of client services, so we have 9 full-time staff, 1 part-time staff, and 3 student workers. And we are in charge of basically all of the samples that come into the lab to get them into our computer system to track them, and then to send them to the individual labs, which I'm going to mention here in a minute, so that'll make more sense. So BACT or serology. And then any questions, phone calls, or emails that come in from our clients, our client care division, we have 3 people there for that. And then the necropsy floor. So that's a lot of protocols, cleaning and disinfection, that type of thing. We have 1 full-time person who does nothing but manage the necropsy floor. So there's KSVDL. Oh, yes.
What was your undergraduate degree in?
Well, I actually applied to veterinary school after my 3rd year, so I was tracking for an animal science degree. I got my prerequisites down in 3 years, which is very, very achievable. There's actually some people getting those down in 2 years now, especially if you've gotten a lot of college credits during high school. And then you can apply to vet school as soon as you have your credits. So I applied after my 3rd year, knowing that if I didn't get in, I'd go 1 more year to undergrad and finish up my animal science degree, but I was accepted. So I went straight into veterinary school. So technically, after your 2nd year of veterinary school, they give you a bachelor's, but once you have your DVM, the bachelor's isn't nearly as important. So technically, I have a bachelor's in animal science, but I didn't really do that in 4 or 5 years. I got that during veterinary school. Very good question. But yeah, there are a lot coming in, and you can get your prereqs done in 2 years now if you push yourself, or you can go the full 4 or 5 years. And then there's obviously the early admit program that you guys hopefully have heard about if you're interested in vet school. And so you still take all your prerequisites, and if you maintain a specific GPA, then you are automatically in and the process is over with. So there's 11 individual labs, like I mentioned, and we're a unique part of K-State because we are a revenue generating unit. So most of the university concentrates on academia and teaching and research. We are the service component, so every academic institution has a teaching, a service, and a research. We're mainly service, but we use those cases that we get in for teaching and for research at the same time. So we really do all three. We accept cases from veterinarians, obviously, and since we are a state institution, we're the only lab in the state, we do accept cases directly from owners, which can be pretty frustrating for them because even if we find out what's wrong with their animal, we can't prescribe them a medication or tell them exactly what to do to fix it. They have to have their own regular veterinarian do that. So we really encourage people to have a veterinarian that they work with. So obviously we're a big resource for practitioners, like I mentioned, so your veterinarian can call us and ask what sample we would recommend and what tests they should do. Field investigations, so when they go out to do their own necropsies, or if they're having an outbreak in a herd of cattle and they need guidance on that. And we actually have a division of folks that will go out and assist with that if they need to, if they need help. We have a lot of industry partners. We do pathology for industry folks, and a lot of other stuff within the laboratory, help with vaccine trials, all that kind of stuff. Collaboration with a lot of other K-State departments and colleges, help develop new tests. We have an entire portion of our molecular lab who is basically developing tests all the time, and then once they are validated, they're put into our service laboratory. Trying to find new ways to help veterinarians. We have an app now for veterinarians so they can get all of their test results right on their phone or their iPad. We also have a somewhat active social media account, depends on who you ask if that's active or not, but we're on Twitter and Facebook. And then we have a YouTube channel where we post a lot of videos that are helpful hints for practitioners. So ways of sampling or ways of doing necropsies, collecting samples, fine needle aspirates, making slides, all different kinds of stuff like that. And there's our website if you guys are ever bored. There's lots of stuff on there. You can subscribe to newsletters. There's maps of disease trends. There's all kinds of stuff like that. Outside of KSVDL, this is what I do. That's my 2-year-old and my 12-year-old dog and my 6-year-old who's eating a donut at the Varsity Donuts truck. So if you guys ever get to Manhattan, hit the Varsity Donuts truck. But it's only open after 10 o'clock at night, except for special days like St. Patrick's Day. And my husband is a deputy fire chief in Manhattan. So no matter what you guys go into, but especially if you go into veterinary medicine, make sure you still have time for yourself because it's pretty easy to forget about that. So any questions in general about pathology, anatomic pathology, vet school, K-State, anything? Yes.
So you said your residency lasted 3 years. Mm-hmm. Is there a range? Because I've heard from 2 to 5 years is the range.
So we have had some residents that have taken boards after 2 years. Those were all residents that got their PhD prior to coming into their residency. So they had a DVM, then they went on and did a PhD, then they did a residency. There are a lot of programs where you do a combined residency PhD, and those are all going to last at least 4 years, mostly 5 years. So it all depends on where you go and what their programs available are. At K-State, we do not have a combined residency program. Folks that have gotten both have done a 3-year residency and then a 2-year PhD after that, so it becomes a 5-year program, but it's not technically meshed together. It's going to be pretty hard to find a 2-year program. And residencies in general across the board of veterinary medicine are 3 years long. So whether you're talking about orthopedic surgery or pathology, they're all 3 years. Good question. Okay, so let's start talking about some cases. So case number 1, I'll call the case of the fading puppies. So this came from an owner. There was not a veterinarian involved. Well, there was sort of a veterinarian involved, kind of on the side. So there were 2 litters. These folks were breeding these dogs. They were German Shorthairs. Approximately 2 weeks of age. There were 2 litters that were not exactly the same age, but they were very close. Puppies were sort of having respiratory signs, but it wasn't very specific. The veterinarian had thought the first one might have aspiration pneumonia because they were trying to supplement feed in addition to what they were feeding from the mother. So they thought maybe the puppies had aspirated a little bit of milk. But the first one on antibiotics didn't really work. And then all of a sudden, 2 and 3 more puppies got sick. So it became pretty evident that it wasn't aspiration pneumonia, and it seemed like it was something infectious. The environment was very clean. He said they had a very good vaccination protocol, very clean whelping area. The puppies were kept with the mother. He was sure they'd gotten colostrum after they were born, and didn't identify any management issues that might be a problem and causing disease. So this is what we saw when we first opened the puppy, and we did only get 1 for necropsy. So let me orient you a little bit here. So the head is up here, tail is back here. These are the kidneys, and we're gonna zoom in and look at those a little bit more. You can only see 1 right there. It's very large, it looks a little swollen, and there are lots of little red spots on it. The liver right here is a little bit pale, and again, we have red spots. And then the intestine, this is small intestine right here, is very splotchy. That's the best way to describe it. So there's multifocal hemorrhages. That's what the red splotches are. You can see more back here. So when we look at again, just a little different view, there's the kidney there. And hopefully you guys can see the different color areas there on the capsule, kidney there, and then there's the liver again, intestines coming down here. And again, the head is this direction. So here's up close. So there you can really see the kidneys. So they look enlarged, and then they look very shiny, and that's because they're edematous. There's a lot of extra fluid in them. And then all of these pale areas versus all of these red areas. And I don't know how well it's coming across out there, but they look really spotted. And that's sort of a telltale for the disease that's going on in these puppies. So this is histopath. So once we take the tissues, we fix them in a formaldehyde solution for at least 24 hours, and then we cut very little sections of them, process those, and then our technicians make those into slides, basically. So they get embedded in paraffin wax, and they get sectioned at 4 microns thick, so that's a paper, put onto our slide, stained, and then cover slipped. And then we look at them. So this is the kidney. This is what we call the cortex, or the outer portion. And then as you go this way, you're moving towards the inside of the kidney. There's pelvis right here and medulla right here, the main 3 portions that we're looking at. And all of this red is hemorrhage. So that kind of shows you what you were seeing grossly, right? All of those red spots. So you can't make it out from this powder, but there's a lot more purple in here than there should be, and that is from inflammation. So this is sort of not that great a picture, but this is a normal kidney that I wanted you guys to see. So this is the glomerulus right here, made up of all these little capillary tufts. And then there's a little space around it, which is called Bowman's space. And then you have all of these tubules. And they should all be lined with a nice single layer of cells. You can see 1 nucleus and 1 cell making up those tubules. So when we look at the kidneys from this puppy, it doesn't look anything like that. So this is zoomed in from that first picture. So we can still see glomeruli right there. This one doesn't look so good. And then you guys can see where we should have those nice purple dots and those tubules with those cells lining them. It's just pink. So when we see things like this, we call it hypereosinophilic, because that's a nice big long pathology word, but it really just means it's all solid pink. So the nuclei are gone, which means the cell has died. So we call that necrosis. So basically we've had cell death of all of the epithelial cells making up the tubules. So the nuclei are gone, and the cellular detail is all gone as well. And then all of these little red to pink dots everywhere kind of filling this space, those are all red blood cells. So more hemorrhage. You can see that up here. You can see this kind of light pink, that's protein leaking into the tubules because your glomeruli are not filtering it out as they should be. More hemorrhage, and then purple dots up here, more than should be, and so those are inflammatory cells. So most of the time, anything that causes cell death that leads to necrosis, you're going to get infiltration of inflammatory cells because they're going to try to come clean it up. Even if they're going to be overwhelmed, they don't know that. So we've had lots of inflammatory cells infiltrate into that kidney. This is the adrenal gland, which we didn't see anything grossly when we looked at it, but when we looked at it histologically, this entire area right here, hopefully you guys can see that it's very pink. and you lose the cellular detail compared to down here. So that's just another big area of cell death or necrosis. This is the liver, and we can kind of see it looked a little speckly when we looked at it grossly as well. And so again, we just have necrosis. So pretty much every organ almost that we looked at in this puppy, there was necrosis. So hepatocytes, they form these nice little cords. They kind of row up where they should if they're normal. This is a portal area with, you can't really make them out individually, but there's a bile duct, an arteriole, and a vein right there. And then you have kind of a pale pink area here, and then this really big pale pink area here, and it sort of fades up into here. So that is all necrosis as well. This is the lung. So there's a little bit of not really normal, but we still have alveolar spaces here. So we should have lots of air in the lung when we look at it, right? So that we have normal oxygen exchange. So these are your alveolar septae that make up the sort of honeycomb pattern of the lung. They're too thick and there's too many cells in them, which explains our respiratory signs. So this puppy was having difficulty breathing because it's not having proper oxygen exchange. And then again, the same thing, right? Lots of pink stuff here. So that's all necrosis and fibrin and inflammatory cells. And then you can see these alveolar spaces up here actually have cells in the middle of them, which is never normal. So those are also in there trying to clean up the debris and the necrotic material that's inside the lungs. Spleen, same thing. Lots of necrotic cells from the infection. So this is canine herpes virus, and it is a really, really common virus, and a lot of breeders have not heard of it. So it's a common thing that we see in puppies. It's also part of the kennel cough complex. So you guys have probably heard of kennel cough. That's actually a lot of bacteria and viruses all together, and dogs might have some, not the other. Adult dogs that are healthy and normal can get kennel cough, and they'll fight it off, and they'll recover and be totally fine. Puppies, on the other hand, especially when they're less than 5 weeks of age, this virus specifically is usually fatal if you don't know what it is and you don't treat it properly. So it's spread through respiratory secretions, usually from the mother. And they can also get it through the placenta while they're still in utero or at the time of birth. So it's really easy for the mother to pass it. And the thing that you need to remember with all herpes infections is once the animal's infected, it's there for life. So the adult may not be showing any signs or have ever showed any signs, but it's usually living in the trigeminal ganglia in the nervous system. And stress is what causes it to reemerge or recrudesce, they call it. So a pregnancy and whelping the dog is a really good time for that to happen. So all of a sudden she starts circulating the virus into her body, she sheds it in those secretions, and then she infects the puppies at the time of birth or shortly after when they're still in the whelping box. So unfortunately, there's really no specific vaccine you can give for this. So there's nothing you can really stop, but the best part of it is that this virus only replicates at low temperatures. Yes?
What's whelping?
Oh, I'm sorry, birthing of puppies. You bet. So that's why it affects these puppies. These little guys cannot regulate their own body temperature very well. And so the virus gets in there, and especially think about it if they breathe it in their nose is a little bit cooler than the rest of their body anyway. So the virus grows and replicates in there, and then it spreads throughout the body. So a lot of these puppies, if you catch it early enough before all that damage has happened to the organs, the treatment is quite simple, and you actually just need to put them under heat lamps and keep them warm. You stop the virus from replicating, then it doesn't spread throughout their body, and it's gone. So, any questions on that one? Yes?
The dogs, like, are they still alive?
Do what?
Are the dogs still alive?
The puppies? No. Sorry. They didn't figure it out soon enough. Yeah, by the time they brought that one in, they pretty much lost all of them. Yes?
Was it the mother's like first litter, or how do they not know shit herpes?
I don't remember if it was her first. I'm thinking that one of them was their first litter and the other was not. A lot of times adults don't show signs at all, so they might not have ever known she was infected. And who knows if she was infected when she was really young and just carried it forever, or if she caught it later on. They brought in some new breeding males, so they didn't know if they were the ones that brought it into their kennel or not. Yes?
Are hemorrhages just internal bleeding in the organs?
Hemorrhage is bleeding, yes, but in these cases there's necrosis and hemorrhage together. So a lot of times if you have cell death and the tissue is sort of shrinking and dying because all those cells are dead, there will be hemorrhage that kind of fills the space in. And that was those telltale signs I told you about. So we call those kidneys turkey egg kidneys. You guys ever seen turkey eggs with our red spotted? So the kidneys are usually the first organ affected in these puppies. So a lot of times that's the only organ we will see with lesions. These people gave this puppy a lot of supportive care. And so unfortunately that made him sick longer, which is why we saw it in all of those other organs. A lot of times we just see the kidneys. All right, now we'll move on to a large animal. Any horse fans in here besides Martha? All right. So this horse has a pretty short history. Unfortunately, we didn't get a lot of detail about it, but this horse was very neurologic. So he was a 9-year-old quarter horse stallion. He'd been in Oklahoma for an undetermined amount of time at a trainer. And he had just come back to Kansas on the 23rd of February. They had noticed at the trainer on the 20th that he just seemed to be a little bit off, but they didn't really give anything specific. The 22nd, he was seen by a veterinarian there in Oklahoma, and they did a sort of a neurologic exam because they felt that they were seeing signs that were associated with some kind of neurologic disease. So loss of menace. So the menace reflex is something that we can check on all animals. It's controlled by the brain, and it's kind of what it sounds like, but it's you have to be beside the animal and you make a type of motion that's supposed to be threatening, if you will. So basically moving your hand towards the animal's eye, and they should blink because they see your hand coming and it's an automatic reflex to close their eye. They don't really control that. This horse was not doing that. So that means there is something wrong with the normal path of the nervous system that is not telling him to close his eye when something is coming towards it. He was depressed, and he was also head pressing, which is a very severe sign in these guys. So head pressing in horses, they will usually go into some sort of corner, whether if they're in a stall, in the corner of the stall, or a barn, or even in the corner of a fence, and they will literally just sit and press their forehead into the corner. Usually their head is down and kind of forward, and they're a little bit slumped over, and they just head press. And again, it's a sign of disease in the brain itself. So they went ahead and brought the horse back to Kansas. They got here on the 23rd, and the next day they brought it to the Veterinary Health Center at Kansas State to the equine department because of these signs, and because they obviously, when the owners got it back, they realized it was not normal. So cortical blindness, so when they assessed this horse, they could not see, and cortical blindness indicates that it's in the cortex of the brain that's causing that lesion, so it's not a problem with the actual eyeball or the globe itself, it's a brain problem. So the pathways and the nerves, the optic nerves. Still head pressing, so obviously that's not a good sign. They did skull radiographs, and they did not see anything. So Martha was just talking about that, but horses can flip over. They're pretty famous for that, and if they flip over backwards, there are some really tiny bones in their head that are very important to be intact. So they have the main bone that they break is called the basisphenoid bone, and it's very, very close to the brain. It is very thin. And if they flip over backwards and hit the top of their head, it fractures pretty easily. And there's nothing you can do for it. It's too deep inside the head, you cannot fix it, and those horses will never be normal. So that's kind of what they were suspecting, that maybe something had happened, but they came back normal with no fractures. They did a CBC, or a complete blood count, so that's looking for signs of infection, the white blood cells, glucose levels, all of that type of stuff, all normal. A chemistry panel on the serum, so that's assessing organ function. So they would have assessed the renal function, the liver function, cholesterol, that type of stuff, which still all goes along with the liver, and the electrolytes, and those were all normal as well. So the horse was still eating and drinking, even with all of these problems. And when they assessed it at K-State, it actually did have a menace on the left and not on the right. So now it was a unilateral or a one-sided without the menace reflex. So they weren't sure if it had actually returned, or if maybe it just didn't get assessed properly the prior time, and it really did have it all along. Unfortunately, the horse did not make any improvement while it was there, and it sort of continued to go downhill. So 2 days later, it was euthanized, and it came for necropsy. So a neurologic horse, especially when it's been in a trainer and not being watched very closely, you want to check for rabies, right? So there's lots of humans I had interacted with this horse, so you would have lots of exposure to rabies. So he did not have a good vaccination history. Some people vaccinate horses for rabies, some don't. So it's pretty variable, and they are definitely susceptible to the virus. So we tested this horse for rabies, and it was negative, which was good for all the people that had been exposed to it. And when we did the necropsy, everything was completely normal except for the brain itself. And this picture is sort of of what's to come, but this is corn with mold on it. So moldy corn is the complete cause of this horse's disease, and we're going to talk about that here in a second. So this is a picture of part of the brain. This is part of the cerebrum right here, and this is pretty normal color up here. So you have the white matter and the gray matter, and then we have this big area that's soft, kind of orange to brown in color, and it looks pretty gelatinous, and that's because it is necrotic right there. Now this picture is when the brain is fresh, right after we've taken it out of the horse. These other pictures are after the brain had fixed. It was very soft and we didn't want to damage it anymore, so we went ahead and just put it into our formalin solution and we let it fix for several days before we took sections of it to look at. So you can't see a lot here, but all of this darker area is actually a large cavitation, which is opened up right there with some forceps. So there's literally a giant hole in this horse's brain. So you would say it's pretty easy to guess why this horse is not normal mentally with cranial nerves, the menis reflex, those types of things that they said they had seen. So this is the histopath, and this is my favorite slide, and I actually took this to a slide conference, and it's pretty blank, right? There's a lot of white space because it's literally one of the holes. So this horse's brain tissue is just gone in this area, and that's what this disease does. So this is another area, so this is an early area, so there's lots of different stages going on at the same time. So this one is mostly hemorrhage, like you guys saw on those other slides of the puppy. So all the little pink dots, this is normal brain tissue out here, all of this kind of light pink color. And then we have all of this hemorrhage and loss of normal brain tissue in the middle. This is another one of those spots, just to highlight, the brain has these really great cells that are called Gitter cells, and they're actually just macrophages like we see in other parts of the body, but in the brain we give them a special name. And they have a little bit of a special function. So these are parts of the brain parenchyma, or the cortex, that tissue, but they have become necrotic, and so these Gitter cells, you can see lots of different sizes of them, they're actually consuming that dead tissue. And so the larger ones actually have that dead brain matter in their cytoplasm. That's their nucleus there, the purple, and then all of the pink. And so the cytoplasm kind of expands as they try to engulf and get rid of all of that dead tissue. This is just kind of a start of one of the lesions. So you can see sort of holes forming, and then these all sort of come together to cause one of those big cavitations. And these are just a bunch of eosinophils, which are really pretty in horses. So these are a white blood cell, and they have all these beautiful pink granules in their cytoplasm. And we see a lot of these with this disease specifically in the brain. So it's called Leukoencephalomalacia, which I know is a really big word, but if you break it down, it makes a lot of sense. So leuko is white, so it affects the white matter of the brain. So we have other diseases that affect the gray matter, which we call polioencephalomalacia. That's a disease in cattle. And then encephalo, meaning brain, and malacia meaning softening. So it's basically softening of the white matter of the brain, right? So we typically see it in horses fed moldy corn, which is why I had a picture of that. Normally they need to consume it for about a month, but it's really dose dependent. So it all depends on how much corn they were getting and how moldy it was. So horse folks are typically very tedious about checking their grain supplies and their sweet feed or their mixed feed, and making sure that there is no sign of moldy corn. The toxin that the mold is producing is fumonisin B1, and so it's actually a fungus, it's a mold, and it makes that toxin and releases it. So it causes, the way it works and the way it affects just the brain is a little bit mysterious to people. The pathogenesis or how it does what it does is not exactly figured out, and it's been around for a really long time. But it causes microcirculatory damage. So it affects the really little vessels within the brain. It basically causes those vessels to sort of die, and then you get ischemia or lack of blood flow and oxygen into those areas. So then the tissue starts to die, and then as it just kind of grows upon itself, and that's why those cavitations get so big. Usually it's really sudden, as it was in this horse. Drowsiness is reported often with this, so the horse can literally sort of like fall asleep while it's eating or drinking. There's other diseases that can do that, but this one's supposed to do that quite a bit. Impaired vision, as we saw in this one. They can actually have pharyngeal paralysis and stop being able to swallow because the nerves that innervate that part of the body and those muscles stop working if that part of the brain gets affected. So it's really dependent upon where in the brain the lesions are happening. Weakness, which may or may not have been in this horse, staggering and circling. So circling is usually another sign of neurologic disease. And typically animals, if they have a lesion in their brain, they will circle in the direction of the lesion. So if the lesion's on the right, they will circle that way. Death usually happens in 2 or 3 days. So unfortunately, this is usually diagnosed at necropsy. And as you can tell from looking at those pictures, even if you knew what it was, there's nothing you can do about it. So supportive care would keep the horse alive, but you're not going to regrow or repair your brain tissue. So once it's gone, it's gone. So we already talked about that, white matter of the cerebrum, which is the name. Usually the outer surface looks kind of normal at necropsy when you go to take the brain out, but as soon as you start to cut through it, then you see those large holes or cavitations. Sometimes if they're really mildly affected, you might only see it microscopically because it might not be large enough to see with your eyes yet. And it can involve the cerebellum and the brainstem as well. So all 3 parts of the brain. So we already looked at those and we talked about it affects the vessels. So that's why the holes or the cavitations usually follow the vessels. And then eosinophils was the
Hey, Martha, I can't hear you. Once your microphone reset, it never reset to something we can hear, but I can't hear you if you're responding. So I'm going to mute myself. Perfect, thank you.
Okay, where did you guys leave off?
I discussed tularemia with everybody while it was silent.
Perfect. All right, perfect. Well, and we'll just keep going. So I was just talking about cytoxoin and tularemia and how they can look alike clinically in these cats when they're sick. So I was just talking about tularemia and how it's a select agent. So a select agent program is overseen by the federal government. And if you work on select agents in your laboratory, there are very, very stringent procedures, lots of inspections that you have to go through. We do not work on specifically select agents in our facility, but if you guys have been to K-State or heard about the BRI, they call it the Bio Research Institute, or Pat Roberts Hall, which is right next door to the College of Vet Med, they do work on select agents. So they have a select agent program there. So they act as our select agent officer for the entire university. So, so again, it comes from ticks. Tularemia, the cat can eat the tick and become infected. You can inhale bacteria and become infected in your lungs, or inoculation. If you stick yourself with a needle or cut yourself during a necropsy, you can put the bacteria directly into your body that way as well. So tularemia is a bacteria, so Francisella tularensis, which I'll have on a slide here in a little bit, and cytoxoin bobcat fever is actually a blood parasite. And so this lives in bobcats and they don't get sick. The tick bites a bobcat, picks up the parasite in the blood that it sucks from the bobcat, and then when it bites a house cat, it gets infected with those blood cells and those parasites that came out of the bobcat, and it is almost nearly always fatal in house cats. So pretty bad disease in the summertime. So that's why it's really important to use tick preventative or tick collars if your cats go outside. Well, we have audio on my camera, but we can't move slides. Oh. All right. So a lot of times these cats live in a rural location. A lot of times they're barn cats or outside cats on a farm, or outside cats in town as well. There's ticks everywhere. So these cats did live in a rural location. The owners had found what they thought was part of a rabbit carcass in their garage 1 week, you can see a K there, week prior to presentation, and all 3 cats became sick at the same time. They were all sharing the rabbit carcass. 1 cat recovered at home, so they didn't really think anything of it. The other 2 cats became really, really ill, and they took them to the veterinarian. So upon exam at the vet, she found them to be extremely dehydrated. They had icterus, which I mentioned earlier, so that's the yellowing, and that's dysfunction of the liver that causes that, and or destruction of red blood cells within the body. Fever, and they had really enlarged submandibular lymph nodes right under their chin here. Both cats were euthanized at that time because of their really poor condition, and the fact that they were outside cats, didn't have a good vaccination history, that type of thing. So gross lesions, so this is what we saw when we opened up. We got one of the cats. This is what we saw when we opened this cat. So the head is up here, the tail is back here. This is what we call omental fat, or fat in the abdomen around the intestines, and this is the spleen. So it is probably 6 to 7 times larger than it would normally be in a cat that size. And then we have all of these really large mass-looking things, which are all actually areas of necrosis. And this is our #1 lesion we see in tularemia. So in a cat that we don't know whether it's going to have bobcat fever or tularemia, we like to open up the abdomen and look at the spleen first. If it does not have lesions in the spleen, if it's a normal size spleen, or a spleen without these white nodules or white dots, then it's not tularemia. It's a very telltale organ. It's always the first organ affected. So these are the lymph nodes that I mentioned. So this is the inside of the cat's mouth. So the tongue has been removed. This yellowish tissue right here and right here. And these are probably about 3 times the size of normal. And those are the lymph nodes. And then I have a picture, I don't think it's next though, of cut section of those after we took them out and sectioned through them, and they were completely necrotic, which is why they were so large. Yes?
So did you have to get like special permission to do this since it was like tularemia? Since it was like
We don't know it's tularemia when we're doing the necropsy, so I'll kind of get to that in a little bit, but if you have more questions, be sure to ask me, okay? And a lot of times, this case is actually several years old. Now we have moved to doing anything we suspect to be tularemia in a biosafety cabinet. This is the intestines, small intestines all around in here, and then these are the mesenteric lymph nodes that live kind of in the middle of all of the intestine, and that's probably 5 to 6 to 7 times as large as it should be. And again, you can see that icterus, that real yellow color. Normally they're pale pink. And then this is those lymph nodes cut open. So all of these pale areas are necrotic or dead tissue. So nearly the entire lymph node. Liver, little white spots, and it's in all of the lobes, and those are all areas of necrosis as well. And the lungs. So they look kind of shiny, and so they have edema in them, so that's extra fluid once again, like I mentioned before. And then I don't know if you guys can see it very well on the projector, but there's white spots all over the surface of the lungs as well, and those are also a bunch of areas of necrosis. This is histopath, and I'm going to fly through these because they're all the same. It's a bunch more necrosis. You guys are experts at that now. So this is liver, all nice happy liver cells out here, and then necrosis and inflammation in all of these pale areas with the more purple dots. Spleen, this is kind of a zoomed out view, and all of these pale areas are the abnormal areas. So normally our spleen is really colorful. We have red pulp, which is the red blood cells, and we have white pulp, which is the white blood cells. And they normally are just kind of mixed throughout the spleen in this type of pattern. So all of these areas are those big nodules that you are seeing grossly. And then when you zoom in, you can't make out anything normal. So it's just all dead cells and inflammation. Lung, same thing. So there's our little white spots that we could see. Normal lung down here, and then areas of necrosis and white cell infiltrate right there due to infection. So we did a test, which we call immunohistochemistry, and so it's staining for the antigen to the bacteria. And you can either use a red color or a brown color. This one we typically use red. And that's a lymph node here, so all the red is positive staining. So that's a lot of positive staining. We don't even really need a microscope to look at that. You'd be able to see it with your eyes on the slide. And I think this was one of the spots in the liver. And then that's just a little bit up closer. Nope, that's spleen, and then that's lung. So very, 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 very positive for tularemia. So kind of going back to her question, so since it is a select agent, even if we suspect it, we have no way to actually totally confirm it at our laboratory because you cannot manipulate select agents without select agent permits. So if we think that that's what it is sent to the CDC. So they're the only ones that confirm it for us. So they take it, they do a PCR test, which is pretty rapid, and then they let us know the results of that test, and then they go ahead and culture it because they like to do subtyping and keep track of all of the isolates of tularemia from across the United States so that they can do tracking, see if the types are moving, could it be related to tick movement, the warming, season changes, that type of thing. And I pulled this map off today. The latest map they have is from 2015, so it's already 2 years old, but you can see that in this area we have a lot of tularemia. And amazingly enough, there's been some in Alaska now. So that was kind of surprising. Maybe they traveled, but it didn't say on the map. But it's been reported in nearly all 50 states over the years, but we're very concentrated here in the Midwest. and that's because of the tick vector. And rabbits. So have you guys heard of rabbit fever? Nobody ever uses that term anymore, but maybe. So that's how most humans used to get tularemia, was they would go rabbit hunting, and then when you skin the rabbit, that would aerosolize the bacteria and they would breathe it in. So that's why if you talk to older folks who used to hunt rabbits, they used to say you have to wait till the second hard freeze, and that's because it's killed the ticks. So the ticks aren't there anymore for the rabbits to get it, and any rabbits that were sick have died off. So anything that's still alive should be healthy, shouldn't have tularemia, and there aren't any ticks to reinfect them. So think about the winter we had this year. It was really, really mild, and that's probably the reason we've already seen cases of tularemia and cytoxoin this year. The ticks are already out, and they are on the animals. So we've had both cases at the veterinary health center already. Last month, I think, actually, they had the first one in March this year. So select agents we do not work with. We don't want to manipulate those because we don't want to aerosolize them or get anybody infected like that. So yeah, we destroy everything that we have, such as the carcass itself, and then tissues and anything else are sent to the CDC. And the tissues that we have in the formalin inactivates bacteria or viruses or any kind of infectious agent that's in there. So that's why we like to have fixed tissues, because they're not infectious. And then we can do that IHC testing, which takes just a day. So it's pretty fast as well. So questions? Okay, anything? Any questions at all? That's all I got for you. 4 minutes to spare. Yes?
Did the cats die?
Those 2 cats were euthanized. The ones that were really sick, yes. The one recovered, yes. So normally, if you identify that infection, it's very treatable with antibiotics in both cats and humans. It's only the ones that are not recognized in people, and it's usually immunocompromised people. The last human case I know of in Kansas was 2 elderly women down in the Wichita area, and they did not know that they were infected, and they didn't quickly seek medical care. So yes, cats, very treatable as well. So if they suspect tularemia, they'll put them on antibiotics. And that's one of the things, if they respond to the antibiotics, then usually you know it was tularemia, and if they don't, then it's usually cytoxomin. There's lots of tests we can do to try to differentiate as well. We can look at their blood to look for the blood parasites for cytoxomin. And for tularemia, you can actually take an aspirate of a lymph node and you can culture it and see if you can grow the bacteria. So lots of ways to diagnose while they're still alive. Yeah. Any questions? Any questions from you guys over there?
No, this was fascinating. Thank you so much, Dr. Almes.
Thanks, guys. Thank you all very much. Have a good night.
Oh, thank you guys for coming.